Christopher Lim. All right, thank you. And welcome, first of all, welcome to the third and the final segment of this debate and this speakers segment of this year's Paris WHO e-simulation conference. Let me just get rid of this thing. Okay. So first of all, I'm the event advisor for this year's conference, and it's a collaboration between EHESP and IUPUI. I'll be the moderator. I believe all of you would have gone through the first two segments, right? And let me just do a quick recap. You guys would have covered, what's the latest trend in terms of social media and how it actually interacts with public health, with impacting on the health outcome, right? And we've seen the good, bad, and the ugly. And we also recognize the fact that social media has been playing a big role, right? And it could be a double-edged sword, especially in this current context, right? And you guys would have also have heard about heard the sharing of experiences from countries like Japan, Malaysia, and the USA. So for today's segment, we are very much privileged to have two very distinguished speakers, Dr. Ian Brooks and Dr. Chris Vogeli. And our theme for today would basically revolve around the sharing of best practices. What are the lessons learned from WHO and US CDC specifically in terms of combating infodemics? We also learn around what does it take, right? Who are the partners that needs to be involved? What are the arsenals of tools that's available to combat against misinformation and disinformation? What are the kind of politics and policies that needs to be involved? Now, whose responsibilities is it going to be? Is it the government, the private sector? All right, so we have a lot of ground to cover for today. Now, without further ado, I would introduce our very first speaker, which is Dr. Ian Brooks. Dr. Ian is currently the director of the Center of Health Informatics, WHO's PAHO Collaborating Center for Information Systems for Health at the University of Illinois. His research focuses on the use of data from traditional and non-traditional sources to understand population health and support public health decision makers. Previously, Dr. Brooks was the Director of Health Sciences and the National Center for Supercomputing Applications, and a member of the CDC External Advisory Committee for High Performing Computing. So without further ado, Dr. Yan, I will pass the time over to you. And okay, it looks like you've already started the slides. So over to you, Dr. Brooks.
Thank you, Chris, and thank you, everyone. It's a real privilege and honor to be invited to speak here. I've been looking forward to this talk for a while. So I would like to talk this morning about a pilot project that we have been doing with PAHO, the Pan American Health Organization, developing what we call the PAHO WHO Anti-Infodemic Virtual Center for the Americas. This is a project that was conceived by my good friend Marcelo D'Agostino at PAHO. And it was really a project that took place for over about a 6-month period last year as a pilot project. We had the privilege of leading this effort, but it was very much an international team, as you will see in a minute. So the challenge we were presented with by PAHO: can we detect new and emerging infodemic threats to public health? Can we determine the truth behind these threats? And can we make recommendations to ministries of health on how to respond? The answer to that question is clearly yes, we can do all those things. But that wasn't all that we need to do. Can we do this within a week? So the idea was, can we do this, see what the situation is, and at the end of the week, essentially start with a clean slate? what is the next major threat that we need to respond to, because the threats keep changing. And if that wasn't enough, we also have to do it with minimal human resources. Because for the idea of being able to be generalized, to be scaled, to be able to do this, not just for the Americas, but this model potentially for all WHO regions, cannot rely on lots of human time and resources to do this. It simply gets too expensive. So this becomes a real challenge. So the first thing we did was really design this vision of how people would work with the center and work with what we're developing. And we came up with these two models. One is when a minister, a public health agency has identified a threat and wants to know, what do I need to know about this threat? So public health decision makers identify a threat. We develop an AI-based search engine that will select a few papers. Now, the challenge here is, if you do a Google search for any topic, you're going to get tens of thousands to hundreds of millions of results. That's overwhelming. That's useless to a minister of health. Can we essentially take those few thousand, hundreds of thousands of papers and distill down to the no more than a couple of papers, a website, maybe a data dashboard? What are the critical pieces of information that are needed? And then provide the links as a result of the output. So think of this as a very, very focused search engine that is tailored to providing just the information the public health official needs. So that's one way of passing through this. The other way is kind of the full response. Can you identify these threats automatically? Can you then do the search just as you would if you were coming in with your own threat? But then how do we make these recommendations? So there's two kind of parallel ways of going through this system. So we came up with split the team into three distinct groups. I should say this was the effort of about 14 senior staff and probably 30 or more students working over primarily the bulk of this took place, I would say, between August and December of 2021 as the proof of concept. So in the introduction to this session, Chris talked about the skills that are needed to do this. On the detection side, this is all about data science and information science. It's lots of AI, it's lots of computer science, very technical. Now, how do you sift through 800 million posts a day, looking for those nuggets that are important? The evidence side is still the data science, because we have to build the engine that will do the kind of filtering for us. But it's also very much research librarianship. And again, information science is a critical part of this. The response part is really very heavily behavioral science. And we also take very much a storytelling perspective. What is the story that we need to tell, or ministries of health need to tell to combat this information? And we've probably already talked in previous sessions about the challenges of convincing people of what is the truth. How do you debunk a conspiracy theory? We very much go with the storytelling. So on the detection side, we developed 3 intersecting algorithms or approaches, one in English, one in Spanish. Well, each of these 3 are in English and in Spanish, and there's a very much a crossover between them. The only reason we limited ourselves to English and Spanish was because of our time frame. Certainly the plans are to expand this on the shorter term to all of the countries in the Americas official languages. So that would certainly include Portuguese and French. So we look at the different kinds of social media. I don't know if you've discussed it in this context. We look at, from our perspective, social media can be divided into 2 very broad groups. There's what we refer to as publishing social media. Those are social media like Twitter, like Reddit, where by default, what you write is shared to the world. It's published to the world. And then there's the sharing social media, things like Facebook, where you get to decide who you want to share that with. And by default, it's more likely to be shared with friends, with family. From a detection standpoint, these have very, very different characteristics. So looking at the published social media, and for this, just the overwhelming volume is is Twitter. How do we look at what is being shared, being published? And we've developed some methods to do that. Really some high-level kind of research librarianship search strings, and then backed up by some machine learning techniques to distill the few 100,000 posts that we download a day to determine what the top topics are. We've also developed an approach where we are using very advanced neural network-based artificial intelligence approaches to try and detect the linguistic signature of misinformation posts. So misinformation, disinformation typically has emotion. Certainly disinformation tries to appeal to certain base feelings. So we can detect the kind of language that's being used in that. And then for the places like Facebook, we actually use their own recommendation algorithms. So if we know, for example, on, let's say TikTok, we've developed a method where now if we search for certain kinds of misinformation, once we find one, we can just set up a stream and say, okay, show me other things that you think I might like, and use their algorithms to recommend similarly connected misinformation, disinformation. And then we automatically download and do the analysis on that, or we're developing the methods to be able to do that. We also look at what other infodemic sites are doing. We are one of many infodemic response groups around the world. We're also looking to see what they are producing. We're looking to see what people are searching for in Google Fact Check. How do we combine all of this to try and understand what's happening? And I'll show you an example in a few minutes. On the evidence side, we partner with a group that was formed during COVID called the Librarian Reserve Corps. This is a group of typically medical librarians, professional research librarians, who have come together to provide an as-needed service, primarily to WHO, on what is needed to get information very quickly from the literature. This is what these people do for a living every day. How do they do this? They have very well established methodologies for determining levels of evidence that they use. And we've also developed similar methods and metrics for establishing the level of misinformation. Now, one of the challenges we came up with is one that you probably already see, which is conspiracy theories. If you try and do a peer-reviewed literature search for the vaccine turning you magnetic, you're not going to find much evidence because scientifically it doesn't make sense. So who would ever have published and study on that? So we have to think slightly differently about how to handle conspiracy theories than misunderstood science. On the response side, I said it's very much storytelling and behavioral science. How do you connect with the audience in a way that they will understand and believe? Storytelling is a very long established practice. The person who leads our team on this is actually by training a children's librarian. She has been teaching storytelling and telling stories for a long time. And that's kind of where we come in. What is the stories that people want to hear? One of our slight differences, certainly than you will hear from some of the kind of fact-checking organizations or some of the other work going on, is that our audience is not the public. Our audience is ministries of health and their communication teams, other public health agencies' communication teams. So it's not what do you want to hear, it's what is the message that you want to tell, and how should you tell the message to your population in a way that they can respond the way you would like them to. And we're also using methods and tools from inoculation theory, so getting into some of the ideas of pre-bunking rather than debunking misinformation, and gamification of some of this. So we've been developing how do you actually, as a part of your response, kind of either clearly or somewhat indirectly identify and teach people the skills to be able to identify misinformation themselves. So that's a very, very rapid overview of what we put together. I'd like to take you through a short example and then finish up with some thoughts and what we learned and some of the challenges we found. So this was a 1-week cycle in early November. We saw something like, started off with social media posts that we analyzed, 3.5, 4, 5 billion posts. It's obviously difficult to get a precise number on that. We had about 79,000 posts that matched our very crude filter in English, about 155,000 in Spanish. When we passed those through our topic modeling algorithms, we got 32 major themes that were new or emerging that week. We had another 111 that came from looking at infodemiology sites. And while this conference is focused on social media, when we're trying to understand what is happening, we have to remember that social media is just the easy way for us to see what people are talking about. The vast majority of conversation doesn't occur through social media. It's just people talking. So we're also pulling a crowdsourcing. So this was essentially asking all of our students, what have you been hearing this week? And we're starting to think about other sources that go beyond social media as input to this approach. So when we brought all these together, we had 145 new threats this week. When we got the really fine, we then had a human look through those 145 threats. And I will discuss some of what goes into making that decision in a minute. When we had gone through, we came up with essentially two major contenders. And we went back and looked at the volume. So this is, what is the 6-month volume? And one of the threats was that the COVID vaccine causes HIV. So when we look at the time series of the volume of posts, and this is all of the posts that we have access to, we see that there's not a huge amount of change over the period. So this may be a constant threat. It's not increasing dramatically. When we look at luciferase, on the other hand, this is clearly something that is very, very rapidly emerging when we were doing this study. So we decided at this point that we were going to focus on this luciferase threat as our example. So here's a post that started it all. This is actually a White House correspondent for a news organization called Newsmax. So she is here talking that vaccines contain luciferase and referring to the connection that Lucifer is another name for the devil, and pulling on the Christian book of Revelations about the end of times, and Lucifer being an example. So this is a very scary thing for this community, just luciferase. It's like, why would they name something luciferase if it wasn't evil? And claiming the people were backing this up, saying, no, if people don't believe us, go look in the patent applications for Moderna and Pfizer's vaccines, and just do a keyword search for luciferase, and it's in there. So this was the threat we decided to work on. So when we went and looked at the evidence, well, clearly there's no evidence that the devil is behind and putting an ingredient in the vaccine. When we confirmed the patent application reference claim, it's completely true. Luciferase is a general name for a protein that gives off light. And it's a very common reagent. Now, anytime you want to see a chemical reaction easily, you attach it to one of these luciferases so that they give off the light and you can see that something has happened. So we found this one paper that talks about luciferase and how it's used in biosensors during COVID-19. So a lot of this was, there's no scientific evidence because this is a conspiracy theory, but there is something to help debunk. So this was what the response team came up with. Here's the threat of the week. Luciferase is in the COVID vaccine. It's a satanic marker. So how to respond about the threat. We came up with some response strategies. So a number of kind of drop downs. Now, the fact that it doesn't, what luciferase means, and we actually tie it into something that is thought to be a wondrous thing, because luciferase is also the chemical that enables glowworms and fireflies to give off light, and people take that as a sign of the wonder of nature, that insects can give off light. And then we show kind of how we came up with this information, came up with a crude ranking analysis. So I'm running slightly short on time. I promised I would look at a couple of major decision points in this work that absolutely require humans. The first is, how do we decide what is the main threat this week? And that's not a simple question. So what is the emerging threat? So as we saw with the luciferase example, is there something that is suddenly getting much more widespread? And then how widespread? Is it very localized to a particular community? Or is it something that's going global? We also have to ask, is this threat locally relevant? So if we are, for example, making a recommendation and classifying a major threat for a Caribbean island country, and the threat is related to, let's say, COVID's spreading by snow, that's not going to be very relevant because they don't get much snow. And we ask, now, what's the potential public health impact? Now, you could imagine a threat that is very broad, widespread, but doesn't have much potential health impact. So if somebody came up and said, oh, COVID initiated from Mars, well, everybody could believe that, but it's not going to change the response. And also, how can we actually respond? And should we respond? Are there times when responding to a threat might actually make things worse? And then how do we classify threats? And this is also something that we found that really helped us with our thinking. Threats, we came up with 3 categories: pseudoscience, conspiracy theories, and misapplication of science. And they're different types of misinformation, but how you classify them really depends on how you go about looking for the evidence and how you go about responding. So one of the biggest unexpected challenges we had was the really piecemeal availability of peer-reviewed literature. So if we make a recommendation from the search engine to say, this is the paper you should go read, how do we know whether that paper is actually available in that country and is not behind a paywall? That's a real challenge. So finally, some lessons learned. Detecting threats, we very much have to use a mixture of AI and statistical approaches. Classifying and scoring the threats is critical to a good response. it is not completely possible to automate this process at this time. I'm not sure that it ever will be. That's why I started saying minimal human activity, not zero. There's too much in here that is subjective and is way beyond any current artificial intelligence. And the bottom line, yes, it is possible to implement the vision. So I'll leave you with a couple of final thoughts. So the technical engineering of this project was easy. Maybe a radical statement, but at least compared to the quite social engineering. And that is very true in general. So whenever you're looking at the technical project, the technical side is almost always way easier than actually the human side of it, the social side of the social technical problem. Thank you. I think we have maybe a couple of minutes for questions, and then Chris will speak, and then I think we leave half an hour for a panel discussion.
Sure, thanks, Dr. Brooks. That was indeed a very, I'd say, interesting and novel way of combining a number of disciplines together, right? So you've got technology, the cutting edges of artificial intelligence, machine learning, and everything, including behavioral science, and also at the same time now policies making and politics as well, right? And how all this mingle together, interact to essentially, I would say, influence and impact public health outcomes. So I think that was indeed a very interesting demonstration of all this interactions between the different disciplines, that clearly has got a lot of influence to public health science as well. So I could see that we have a question from the audiences with regards to the topic, right? And it says, now, does the system analyze video posts? How does the system consider cultural and political perspective of individuals?
So those are great questions. Video posts is something that we have been working with, and it's something that Chris, CDC Chris, and I and others at CDC have been talking about for a while, and we're actually working on together. More and more of social media is being shared on platforms like TikTok, which are very difficult to handle. So we've actually been developing data analysis pipelines or workflows where we can take the outcome of some of this kind of snowball sampling type work that we have developed to identify those videos, and then develop the tools to automatically download them, extract the language from them, and turn that into text that we can use with our text analysis approaches. This is something that we're still working on. It's a real challenge. But yes, it's something that we are adding in. It's much harder than working with text-based social media. But yes, we are very aware of it and are doing. I would say that for the second question, the issues of politics and similar topics are very much part of the two human decision points. What is our top threat? So do we want, is it better to come up to respond to a threat that is maybe generated by your political leaders? Or is it better to respond to a different threat? And the other human decision point of how do we make this response? So do we, if it's the president who is originating the threat, you may respond to that somewhat differently than if it's an anonymous disinformation bot. You have to, because people are going to have very different relationships to a well-known human politician and an anonymous, well, somebody on social media said something.
Great, thanks, Dr. Brooks, for those responses. Let me see if I've got any more questions here. Yeah, I guess the other question I see here is with regards to the fact that you have mentioned that right now you do not see that this piece of work that you're working on and your team is working on is not in the, I'll say, foreseeable horizon, right? That is, it can be fully automated or autonomous. Now, what do you see as the main barrier from? Is it technology? Is that the disciplines behind? And where do you see would be the tipping point that's required for this to totally change and made it to be a fully autonomous in nature? I'm not sure if the question's clear for you.
Yes, from a purely technology-driven perspective, the technology is not there yet. There are certainly things that can go a long way towards it, but there are so many human decision factors. We are nowhere near building in all of the knowledge of behavioral science to knowing how are people going to respond to this threat. Partly because behavioral science doesn't know the answers to all these questions. They can come up with the best guess, but it's predicting the future. I'll give one brief example of the limits of technology. When we're looking at Twitter, just trying to determine are people happy or sad about a post is very, very difficult, because you only have 140 characters to work with. And for a topic that is somewhat contentious, like a lot of public health issues, a lot of people use sarcasm. So, and I can give some examples where a human will read a post, and without knowing that the poster's background and beliefs, you will never be able to tell whether the post is at face value or is sarcastic. And I am 100% convinced that a human will never be able to tell without knowing more about the background of the person. And if a human can't tell, there's no way you can teach a computer to tell.
Absolutely true. I think that clearly demonstrates, I guess, the complexity, especially around the discipline of NLPs, right? Natural language processing itself, which is, I think, one of the biggest area that requires a lot more digging in, I guess, investigation, especially from a research standpoint, right? So very well. Thanks, Dr. Brooks, for sharing your thoughts and your experiences and this really in-depth and intriguing discipline and piece of work that you're doing. So thanks, Dr. Brooks. So right now I'll introduce the second speaker of today. That will be Dr. Chris Vogili. Hi, Chris. So let me just do a quick introduction for Dr. Vogili. He's currently the acting vaccine confidence and demand lead in the National Center for Immunization and Respiratory Diseases at the US CDC. His current role requires him to coordinate CDC's portfolio of work to build public's confidence and demand for all vaccines. Before he took on this role, Dr. Vogeli was the head of Insights Unit, and that actually requires him to monitor and mitigate the spread of misinformation and produces the CDC's State Vaccine Confidence Report. Additionally, Dr. Vogeli works with US and foreign government agencies, university partners, and international organizations to build their capacity and to rebuild trust in government and defend democracy from disinformation. So lots of responsibilities. So without further ado, I'll pass the time over to Dr. Vogeli. Over to you.
Thank you, Chris. Let me share my screen. Probably turn on from the beginning. Let's do presenter view. All right. Yes. Thank you, everybody. Good morning, at least from this side of the world. I'll try to wake up as this conversation continues. But yeah, I'm here to talk about how CDC deals with the problem of mis and disinformation, health information integrity more generally. First, these first two slides are probably a review for some of you, but still good level setting, right? That constantly changing public health guidance and mixed messages from authorities contribute to this noisy, crowded information environment. And, this was especially problematic during the pandemic, especially in those early months, because we just saw so many people turn to social media when social isolation took effect. Screen time averages spiked to over 13 hours per day in March 2020. And a lot of Americans just really reported feeling overwhelmed by the amount of information on COVID. And I go back to this idea that, especially with the novel virus, there was guidance that needed to be changed, mixed messages by different groups. And so it just added to the confusion. And part of that is social media. And it becomes really difficult for people to understand, how trustworthy is the information I'm being shared with on social media, especially when it comes from friends and family. And, why wouldn't you share something that you thought would protect your friends, family, loved ones? And it just perpetuated this misinformation being spread. And in an infodemic, this is another point folks are probably really familiar with, but these credible authoritative voices really needed to compete for attention against misinformation. And especially when the misinformation was packaged to provoke these strong emotions and take advantage of how social media platforms were designed. We often talk about that it's much more than having the more prominent share of voice. It's ensuring people have the right messages through the right venues and through the trusted messengers necessary for them to believe it. So as the information environment is really shaped by the media, social media platforms we access, and just our general social networks on and offline, we had to figure out a way to address, really first identify and then address these conceptions as they went on. And where we eventually came to the conclusion was that, understanding these underlying themes and developing programmatic and communication approaches that address the themes is critical to better addressing the challenges of an infodemic. And one thing I'll call out here is that, a lot of people continue to think that misinformation is just a communications problem. But from our perspective, there are very specific programmatic changes that can occur and need to occur to help address these. And now I'm going to dive into really our way of thinking about this, how we approached it. And I have noticed that this same approach is really helpful regardless of the type of misinformation. So let that be misinformation from foreign aid or foreign governments or extremist groups, sex trafficking, climate change. This concept has been helpful to us. And we start with this point of needing to get really clear on what it is we're looking at. In our lane, we were really interested in how the misinformation impacts vaccine confidence. So I'll keep referencing that, but just a call out that, you have to get your definitions, your frameworks, your strategies really laid out from the get-go to really help drive a whole organization to address it. So just for reference here, when we talk about vaccine confidence, it's the trust that patients, parents, or providers have in the recommended vaccines, the providers of the vaccines, the processes, policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. So when we're looking for misinformation, we're looking for those pieces that impact some place in here, right? That it's misinformation that about the vaccine, the people giving it, or the more nebulous part of what we call the vaccine system, that last bullet. And we continue to notice that really it doesn't have to be vaccine specific. Things that discredit government in general discredit the vaccine system vicariously. So we were still concerned about those. And when developing approaches for it, most public health issues, or at least all that I can think of, there is a way to categorize folks on their acceptance of whatever health practice you want them to do. They're either gung-ho or really aching to do it, like when the vaccines first came out, the people lining up early, all the way to people that would never get the vaccine, they're absolutely refusing. And the approaches we take for these folks is different. A lot of the times we focus on what we call the movable middle. I have a whole shtick about that, and that it makes us think that there's an unmovable piece down here, and so it's not worth our time, but that's a conversation for another piece. But just to understand where people are at and how this could affect their decision making when it comes to getting vaccines, implementing practices for climate change prevention, or whatever it is. So we had to identify frameworks and strategies to really help us. One that we found eternally helpful, at least in the vaccine space, was the BES model, this behavioral and social drivers framework. And what it is laying out those pieces that lead to vaccination uptake, how people think and feel, social processes, motivation, and then the practical issues that might get in the way. But when we're looking for misinformation, here we go again, right? We're looking for that misinformation which may distort somebody's perceived disease risk. So misinformation about that nobody really dies from COVID, it's all a scam, or whatever narrative you want to pull into that, those are the ones that we're concerned with. And additionally, social norms, the people spreading misinformation that nobody's getting the vaccine, a whole slew of societies or agencies are getting laid off because they have refused to get the vaccine. These are things we're also concerned with, because it's then playing into people's perception of social norms. So I continue to think starting off with good frameworks is a good place to begin. Then we developed our Vaccinate with Confidence strategy. It's centered around these three pillars: the building trust, empower healthcare personnel, and engage communities and individuals. And a lot of our work focuses on that first part. We see trust in government, trust in science, health information as a real core piece of prevention when mitigating and addressing misinformation. So with this, for example, building trust, we're looking to ensure however we react to misinformation, we're communicating transparently about the processes for approving, authorizing, making recommendations, and then ensuring folks have the correct information through regular updates, but updates that don't overwhelm them, right? This infodemic principle of just so much information out there. So we try to align our strategies in this, but we also recognize through the pandemic that the misinformation is fairly targeted in that it seems to hinder some place in what we call the ladder to building demand. That, misinformation that discounts the benefits of the vaccine, if people start to accept that, then it's hard for them to move up that ladder of finding it convenient, desirable, normative, and then necessary. So we're looking to kind of address these issues before they become a problem. So we found a need to really respond quickly to information being spread, but a lot of our standard mechanisms didn't fit with a rapid response mechanism. So things like the National Immunization Survey or other monthly surveys doesn't help you when the narratives are changing day by day, especially in the throes of the pandemic. So we needed to identify, how can we identify these themes quickly so our programs and people can address those. So we created the State of Vaccine Confidence Insights report. They were originally bi-weekly reports, but now they're quarterly, and we do more topic, region, demographic specific ones, but that's neither here nor there. But the reports themselves are trying to emphasize the major themes that influence vaccine confidence and uptake. And for us, we're not sure if I can use a colloquialism, the juice is worth the squeeze, or it's worth the effort to address misinformation head on, instead of focusing our efforts on a prevention space with this. And we continue to think that addressing public's questions, concerns, frustrations will solidify, give people that resilience to misinformation, because it just seems like that's the place where misinformation can foster, and it probably has a good lane for uptake. But then also identifying emerging misinformation and then trying to get out information ahead of it. But I'll tell you, that's complicated, especially as there's just so many narratives being put out. You know, how do you identify what's the priority when there's 3 new pieces, 4 new pieces of misinformation? And we're not trying to overwhelm folks, right, with just by addressing all of them. So how do we go about identifying these themes? Right, we collect data from over 24 quantitative and qualitative data sources, and social media is definitely one of them, but we never felt that that gave us the full picture. And we pulled in all of these other components: the news media monitoring, surveys, polls, even peer-reviewed literature, questions to our National Call Center, CDC info. We even use web metrics, Google Trends, Adobe Analytics to identify, you know, what are those changes going on in people's search patterns, and looking at websites. But we then have analysts that are dedicated to each of these streams, and we try to keep them fairly isolated from one another, because we don't want them influencing what other folks are seeing, because each analyst is trying to identify themes in their lane, and then we come back together and talk about it and look for similarities and differences between those. So a lot of it is this thematic analysis approach, but the integrated analysis, as we call it, is probably where we see the most benefit. You know, how does the social media story compare to the news story? And a great example of that is when we authorized booster doses for kids. News stories were very clear that, you know, they were available, where folks could find them. But then you turn to social media, and that was the greatest increase in vitriol I have probably ever seen on the response. Suddenly, folks were calling each other murderers, see you at your kid's funeral. And understanding that difference was really important to us, because we knew at least a better direction in how to proceed. We also assign a threat level relative to vaccine uptake and information spread, but I'll get into that more. And what makes this report a little bit different than others is other social monitoring listening reports, is that we really felt it was important to include suggested actions, ways to act, as we call them, to address the themes, and then provide support through consultations, boot camps, trainings to build capacity as well. The report itself is disseminated to about 1,000 internal and external partners. And that's where the identifying the recommendations becomes problematic, because these partners run the gamut from local community-based grassroots organizations to WHO and other governments. So trying to identify how folks should respond to that often leaves them a little vague. So that's where the consultations and the additional assistance comes in. Just to go back here for a second, because I left off third-party reports. You know, there's, especially with COVID, but vaccines in general, there are a lot of great people doing work in this space. So incorporating what other folks have done, if it's methodologically rigorous and actually meets the needs identified, we found really valuable. But this is the general methodology we use. This is for when it was a 2-week process. But the reason I'm showing this is that I want to indicate that it's a time, people-intensive process, and it's really iterative. It's pulling data, getting together with the analyst, identifying those themes, but also the overlap, the consistency between them, but the differences as well. And then they go back again, pull more data, we meet again to talk about it. And then we've created a code book to help us really lump these together. So if it's misinformation or themes about vaccine safety versus vaccine effectiveness versus to the vaccinators, right? It helps us start to think about how to create these recommendations. But after we list themes, we describe the type of themes that we have to then go back, pull again. We usually meet again, draft the report. And then we create these scalar judgments, right? Which I think, yeah, that's the next slide I'll talk about. But that often requires more data. So it's a team of 8 analysts and then a team lead, myself, and it just becomes a lot. So AI methods are always looked to as a interesting avenue forward. But what do I mean when we assign threats to it? Much like what Ian was saying, you have to really figure out how this is going to impact whatever issue you're dealing with. For us, being vaccine confidence, we really incorporate this piece of, to what degree do we believe this may lead to vaccine refusals and decreased uptake, versus maybe it's just supposed to trigger hesitancy to vaccination, as opposed to a low risk to vaccine confidence. We added a positive sentiment, but through this whole pandemic, I think we've used that 3 times, and that probably speaks to how the pandemic is going more than anything else. But then because we track this longitudinally, we can say whether or not they're increasing, stable, or decreasing. But I'll go back up here for a second, because identifying, the threat that it serves or that it has to whatever your goal is, there's no clear guidance on that. And I think at CDC and other public health agencies and ministries of health, we're a little bit lucky in that we have a group of experts who have been working in the space for a long time. So it's usually expert review that's determining what we think the outcome is going to be, but then including this notion of wide reach and how pervasive is it, right? And through the social media, through news, through the CDC info request, we're looking for its spread. But much like how Ian talked about, there are special considerations here. A lot of our view and looking at this is from a national lens, but when we see themes targeted toward vulnerable populations, that's a different story, right? It might not be spreading that much when you're looking in the national context, but when you're looking at a specific group, if it's misinformation directed toward people who are pregnant, and we see it spreading there, that's a little bit more problematic because the outcome for that is more dangerous. All right. So this is the format's changed a little bit. We made it more bulleted since this, but we do still provide some narrative, give some background, maybe about where this theme is coming from, the concern is coming from, and then we start to talk about the perceptions, concerns, and threats. And now those are bulleted out, but what are those things that are being talked about with the potential to drive vaccine confidence up or down? And then we also now have a section dedicated to misinformation themes where we bullet them out, provide examples of them. But then we go back to this notion of the ways to act, right? I don't want this report to be a doorstop for somebody or just something they print off and then throw away. It needs to be actionable, and we need to provide ways that folks can actually use it. And I'll go back to what I started off saying earlier, that, a lot of folks think this is a communications problem, but we have these 3 different lenses by which we craft the recommendations. The communication, definitely, right? What content or information is missing? What messages do we need to disseminate? But there's also programmatic ones. What can we do to improve upon this issue? Maybe it's increasing vaccination sites in a particular area. Maybe it's partnering with a different organization to be a trusted messenger to address it. But the third one then is research. What do we still not know that we could learn from survey data, focus groups, or traditional lab research? And yeah, it's probably no surprise that since the report began in February of 2021, we've seen and continue to see the conversation shift and change. Our first report in early February really focused on the frustrations consumers were having with getting the vaccine, who was eligible, where could they get it? And now it's a lot of these similar issues throughout the pandemic, but they just seem to have staying power. These concerns about unknown future side effects are a big one, reproductive health concerns, but they do change rather rapidly. So how are our reports and how are readers of the report using them? We did an evaluation of it, and these were the top selections for how folks are using it. One, informed communication strategies. That's a no-brainer, right? What messages to put out, but also helps folks improve their personal understanding of vaccine confidence issues. And like I said earlier, inform partnerships with groups, other organizations that could be the trusted messenger to get that out. And then improve understanding of vaccine confidence and access issues across special populations. And then really what we hoped it would do would inform prioritization of vaccine confidence issues. The report is not supposed to be an inventory of all of the issues over the past 2 weeks, month, quarter, but really to help prioritize those, because it's an infodemic, right? We don't want a million messages going out again to the public. So how do we ensure that that doesn't happen? So the takeaways I have for this is that first, there's no silver bullet. Limited tools exist to address mis and disinformation. And while many current tactics like requesting posts, message takedowns do limit misinformation to exposure, and debunking misinformation alone ignores real larger social and cultural forces that cause misinformation to gain traction. So I think that's just another callback to this idea of we think it's valuable to really focus on those questions, concerns, frustrations to hopefully not give misinformation space to grow and be believed. Then I think there's this question of requesting post message takedowns. You know, from the CDC perspective, we have never asked folks to remove stuff. We do see it as our role to ensure that folks know what is accurate information, and what the social media platforms or local agencies do with that's a different story. It's not out of our, or it's out of our hands. But if they want to implement whatever policies they have, whatever. But we do have a duty to ensure that the correct and accurate information is out there for folks. And then I'll throw out that traditional risk communication and social media outreach approaches just aren't sufficient. I continue to harp on this idea that understanding these underlying themes to misinformation as it spreads and developing programmatic and communication approaches is really critical, especially as we continue to see declines in trust, at least in US government, CDC. And how do we go about rebuilding that trust? So during the next pandemic, folks can believe the information, follow the behavioral guidance we give them. So to address the current infodemic and future health infodemics, we just always make the case we must use an evidence-based approach, leverage socio-behavioral and epidemiological insights, and execute a plan transparently to reduce the spread and harm of misinformation and promote accurate, credible information. And I'll go back to this idea of social media here for a second, because it's usually one of my talking points that when future generations look back on the 21st century, they're going to see more in common with it between the 21st and the 16th and the 21st and 20th, because of this social cohesion breakdown that was occurred from the existence of the Gutenberg press and to now what we're seeing with social media. And I would just always make the case that the problem wasn't the press, it was how we dealt with the information that came out of that. And policies were initiated, but not before a lot of problems occurred. You know, printing flyers about witches in your community definitely did not serve social cohesion well. But that didn't mean the printing press was really the problem. Now, I think this gets complicated when you're talking about algorithms and how those are used to promote certain videos, posts, and as they're trying to generate clicks. So it is a little bit different of a game here, but it's still focused on that this is not going away. We're not going to go back to a space where information won't be shared quickly. And I continue to think that this is the quintessential problem of the information age. And we need to learn to work in this space that recognizes that we're not going back to the 80s, 90s, whatever it is. All right, well, that's what I got. Thank you. Stop sharing.
All right, thanks, Dr. Vugile, for sharing that very insightful, I guess, methodology, right, which US CDC has been using to debunk many of the misinformation, disinformation. Okay, I could see one question is coming from the audience is, now, is there any collaboration from social media companies? Has there been any changes in terms of the current regulation based on the following reports that you have presented? Now, what are the challenges while presenting to policymakers? Does this system detect the source of misinformation, and how do you handle the source of the information itself?
Okay, all good questions. The first one about working with tech platforms. So even before the pandemic, we had relationships with tech platforms, but fully focused on ensuring that we had a good understanding of how the system worked and giving them accurate information. And even during the pandemic, that was the relationship that existed. We pushed information to them. We told them what was misinformation, but I'll say I don't think I ever had a meeting with them about misinformation, but there were a few people on my distribution list for it. But yeah, we would just tell, include in this report, right, what is the misinformation? And then, like I said, they would do with it what they want. I never have advocated or asked anybody to remove a post. And I'm not sure if anybody at CDC has, but you know, it's my general ethos, right, of ensuring the accurate information is out there and what independent parties want to do with it. That's out of our control. The second question I already forgot because it's morning.
Yeah, sure. It says, okay, what has been the changes? Yeah.
Yeah, gotcha. In terms of policies, I'm not sure anything has changed. If we're talking about regulations, laws put in place, but instead the changes really revolve around changes in talking points, social media posts, the strategies. By strategies, I mean, you know, who are we partnering with to get out the trusted message? So examples would be really focused on, you know, if it's spreading in a very particular community, ensuring that those trusted messengers for that community has that accurate information. In terms of programmatic changes, it really is, you know, if we're seeing a lot of people with frustrations because they can't find the vaccine in their rural community, well, let's dive in a little bit. Where are those frustrations coming from if we're using tools like Meltwater to identify the cities, regions, and then let's talk with our vaccine clinic folks to get stuff out there for them. So, yeah. And then the third one, see if I forgot the second, I forgot the third.
It's, well, I guess you pretty much have handled that, right? So it's now how, you know, does the system actually detect the source of the information, and do you deal with them, right? Yeah.
Yeah, as from my team's perspective, yeah, we've never gone after the source or tried to get them banned or removed. And even in our reports, when they come out, the post pictures and identifying information are fuzzed out so you can't see them, because we continue to be concerned about ethical considerations around this work. And even if people are sharing misinformation, the last thing we want is social media to go after them in a way that's damaging to health, to trust. So we try to walk that line, and it's a difficult line to walk, especially as we continue to think about, what is it, the dozen people that share 70% or 80% of the misinformation. But we're still going at it from a very public health standpoint, that we have a duty to all citizens, regardless of their beliefs. So we try to do the best we can.
Yeah, sure. I think your role in CDC is really just, you know, more providing education, information and all, right? But you don't necessarily have the jurisdiction to I guess enforce.
Yeah,
that's basically what you're saying. Okay. Yeah. Thanks, and I do see that Liana has raised a hand. So Liana, over to you.
Thank you so much, Chris. Thank you, Dr. Mugali and Dr. Brooks, for being here, and it's nice to see you both in person. I just had a question about if you had any internet. Well, I think you probably answered one of my questions, which was, were you able to source if this information was coming from international sources or if it was only within the United States? And I also wanted to know if there is any intention for like international collaboration on something like this project moving forward.
Yeah, I can answer that from my lane. International sources, yeah, there's some narratives that we can detect are both spreading more in international context, came from international context, but it's something, it's a trope that we often say, the US doesn't need other countries to make their misinformation. We make enough on our own. But that's where it also gets kind of interesting. Dr. Brooks brought up the vaccines giving you HIV. That was one where we did see this notion of VAIDS, vaccine-acquired immune deficiency syndrome, at least when that term became popular, that was spreading in this a very particular region of the world, and it continued to spread long after it had died down in the US. So that becomes interesting, right? That being a domestic public health agency, we really focus on what's going on in the US, but ensuring that our partners internationally knew that was spreading, and any advice we could give, yeah, definitely we would work with them. In terms of intention for collaboration, I think we actually do a good job here. We work hand in hand with WHO. We've provided trainings on infodemics, and even this methodology and vaccine confidence to, I'm trying to remember the number, about 1,400 people in 133 countries so far. But also we have our global immunization division, who has a vaccine confidence team that does dive in and go to countries to help them build their capacity and implement a methodology like this.
Thank you so much.
Great. So far, I do not see any further questions for your specific segment, right, Dr. Bugoli? So let's open up the floor for, I guess, the general discussion, right? Especially with regards to today's theme, which is, what are some of the best practices we would like to see, that's coming from WHO, from US CDC, whose responsibilities would that be in terms of, I think both Dr. Brooks and Dr. Fugili touched on in terms of, the partners that needs to be involved in this fight for infodemics. So, whose responsibility should it be, right? Should it be lying with the government, the state government themselves, or would it be the private sectors, the owners of the social medias? I would really welcome participants to make, in order to make this more interactive, right? So raise your hand, and then we will pass the time over to you so that you could ask your questions directly to both our distinguished speakers. So any point in time, anybody? All right, I do see that there is a question as well that's coming up. All right, it reads now, and this is a question for both of you, right? And since both parties have been involved with primarily, dealing with state of, I would say, head of states and governments of your respective countries, right? So the question goes now: what is the most pressing needs for governments or health sector or public health sectors, right? From the perspective of handling and dealing with misinformation, what are the real priorities, right? And maybe I would just add on to that as well, especially, if the government is not promoting, I guess, I think to earlier on Dr. Brooks' point, right, that is one thing for an anonymous individual to say something that's really untrue or half truth. I think the most difficult part is around dealing with half truths. All right. So of course, and then it's a totally different scenario if a head of state is also saying a similar thing and spreading misinformation or disinformation to that matter. So maybe Dr. Brooks, you wanna go first with this?
Sure, it is a really interesting question. I think one of the things I'd like to say, we wish we had Chris's resources, and most countries wish they had Chris's resources with the CDC. We're dealing with countries that have a total population in some of the Caribbean countries now, a couple of 100,000 people. The Ministry of Health is tiny. They have they have the same responsibility to their population as CDC has to the US. But they maybe only have 4 or 5 people to do all of the work we've been talking about, if that. So this is where why one of our goals was have them be able to get a instant result, like a Google result that will give them the information they want. It's very, very challenging. I'm not going to say that is part of the problem that we've really solved. We're working on it. But how do they get to that critical piece of information really quickly?
Right, great, thanks, Dr. Brooks. Dr. Vogeli?
Yeah, I would say my answer is aligned pretty well with Dr. Brooks on this one, that, even for those agencies that do have resources, it is very time intensive, labor intensive without additional AI machine learning tools. And I continue to be concerned that as the pandemic winds down, the interest in misinformation and funding for it might also decrease. So ensuring that folks know, especially decision makers, that as I ranted about earlier, that this could very well be the quintessential problem of the information age. It's not going away, and that to be prepared for pandemics in the future, we need to focus our efforts in this space, but also to make it a priority to not only maintain trust, but start to build trust in our communities. Even before the pandemic, I was going around CDC presenting on results of declined trust in government and how 80% trust in CDC wasn't good enough. And now that it's declined to 59%, it just makes me more and more concerned. So lumping building trust and maintaining trust through specific programs, initiatives, and interventions as a public health function, I think is really important. But I want to go to the tools for a second, because we are presented with a lot of AI tools to help us do our work, and they're great. They're wonderful supplements to it, but what we really need is advancement in that space. We talked about it earlier, but one of the things that we continue to struggle with these tools, especially the AI dashboards, is that it doesn't give us the specificity and the context needed to make real programmatic changes. So, when somebody or a tool says that there's a lot of people talking about vaccine safety concerns, okay, there's a lot of them, but even when it gets more specific, like myocarditis, what is it about myocarditis? Is it just they're scared in general? We continue to see these very specific narratives around myocarditis and other issues. But for example, it'd be like myocarditis in a specific group of people that have a specific pre-existing condition. Like that makes it much more actionable for us, as opposed to just myocarditis or just safety concerns. So I don't know, much like Dr. Brooks, I don't know if the tools will ever get there to where they're understanding the context and the connections between these, but that's where we would hopefully go. And I think it's definitely needed. And final thought in there is that we need a good trained workforce to do this. Right now, it's a lot of people with overlapping skills and interests. But as we continue to see in these WHO trainings, there's a specific skill set needed. It's a wide skill set, but a specific skill set nonetheless. And developing that so we have the workforce that can do this effectively is really important.
Great, thanks, Dr. Vogeli. Yeah, and the next follow-up question that came out, right? It's really regards to I think what both of you have been talking about in terms of the resource disparity, right, between the low middle income countries versus that of a developed country. So one of the participants specifically wants to know now, what would be that one single suggestion that you have, very much specific to a resource constrained country, right? So one of those LMIC, so which I'm sure Dr. Brooks you have worked with many of the times, right? So what would be that one single recommendation that you would provide to a LMIC country, all right, in terms of dealing with what's a problem that infodemics can bring onto the country? And is there an international regulation that needs to be enforced or at least put in place, right, in terms of dealing with infodemics within social media itself? So, yeah, over to you, Dr. Brooks.
Some really difficult questions.
Indeed.
I think I would just the first couple of things that come to my mind is that even though a lot of countries do not have the resources to respond to infodemic threats, particularly those that originate from social media. Social media is so prevalent everywhere now that the threat is going to be there whether you're in a country with very few resources or you're in the US. So just because you don't have the resources to respond to the social media threat doesn't mean it's not just as viable. And in some cases, you might argue it's actually a greater threat because it also goes to health literacy. And sometimes the health literacy in LMIC countries is not as good. So and sometimes there's an even greater threat.
Yeah,
right, thanks.
Yeah,
Go ahead.
I was just going to hop in and say, when we go into countries with varying resources to build their capacity, especially trying to put in a methodology like we use, WHO and CDC have really done a good job, I think, about laying out what we call the mountain bike resource model for it, the sedan, and then the luxury car version, to where the mountain bike, as we call it, are just those basic things that folks should be doing, and Ian touched on them, that dedicating at least some portion of somebody's time to reviewing social media. And I'll say, coming from local and state health departments, even in the US, they don't often have the time, resources to do that. 5% of somebody's dedicated time will be on communication to the public, and 2.5%, 1% of that we're asking to go to social listening. It's just really difficult. So I continue to make the case that, ensuring that leadership is aware that this is a problem moving forward is just really important. I had another point with that, but I forgot. So we'll go to the next question.
All right, no worries, Dr. Vugile. So I see that Yukiko, you've raised your hand. So over to you.
Yes, I'm sorry if you guys already touched on this, but I just wonder how the government get involved in this in misinformation. I mean, how does the government support the research on misinformation, and does the government support support financially on the research, for example?
Right, thanks. Go ahead.
So
Anyone?
I can maybe touch on this in a way that is a little harder for Dr. Vugile, because I work for the state government, but not as a public health official. And this was a question that came up, or a topic that came up a little bit ago. I think we have to make sure that we don't enter back into you probably heard of the panic neglect cycle of public health funding. So now it's a panic, something like a pandemic, huge amounts of money are thrown at it. 6 months later, it's over. Oh, we don't need to worry about public health funding anymore, and it's an easy thing to cut. We have to get away from that model, because one of the things we saw in the US, and talking about local health departments in my own state of Illinois, we saw local health departments absolutely decimated in the years leading up to the pandemic because of lack of funding. And we were down to some departments having 2 people. And then suddenly you're asking them to respond to an emergency. And I'm already starting to see some of the thing that Chris was worried about, the infodemic funding starting to become harder to get. And the way to respond to the infodemic is for the education component to take place so that people are already health literate and response to threats before they suddenly start getting bombarded with them. This is the time to be investing and making sure that we have a good response to the next problem, not ignoring it until it hits.
Yeah, and I don't know if I have anything to add to what Ian said. That's spot on. We do fund research in this space. So I think all of it is COVID money. Some of it's now being transferred to just general pandemic preparedness, but relative to other funding, yeah, it's fairly strapped. And we just continue to make the case for it by including it in strategic plans, research agendas, and research priorities. So hopefully making it easier for decision makers to fund it.
Yeah, sure. I think that's definitely becoming more and more difficult and more challenging, I guess, for both of you and for your job. And I'm pretty sure the very fact that WHO, together even with the Biden administration, is signaling, right, that we are almost at the end of the tunnel. And I think that sort of messaging probably wouldn't really help with some of the work that you're doing, especially in terms of potentially even getting additional funding, right? I would suppose that, and Chris probably could, vouch to that, right? Is that helping you? Is that not helping you?
Well, we haven't seen the trickle down from that yet. Where our team is concerned about that is just the perceived risk people have of COVID and their desire to get the vaccine. But yeah, I'll leave it there before I get in trouble.
Right, sure. Liana, over to you.
Yes, thank you. I just wanted to ask you both. So we, over the past, 3 weeks, most of us are public health students or just starting off our careers, and we have learned, so much over this period of time from yourselves and from other speakers. But if you can give us one piece of advice, starting off our careers and having this in mind, that interacting on social media is something that will remain with us. It's not something that will go away. Where can we continue to educate ourselves on this topic? It's not something that's really covered in our training so far, and that's one of the reasons we chose to do this conference on this topic. But where would you say would be the best way for us to continue to educate ourselves on this and to keep abreast of what's happening, and just being aware and using that to guide us in our future careers?
Yeah, I'll hop in. One, I would say that there are a lot of trainings out there, probably not as many as there should be, but I think of like the WHO's Infodemic Manager training. It's a 48-hour training, but there's a lot of great information in there. And additionally, I would say reach out to folks working in this space. A lot of us have opportunities for collaboration, to work on projects with students as well. But then I continue to see fellowships being developed, like one at Brown University, and just leveraging those that do exist. Yeah, I think that's where I'll leave it.
Yeah,
Thanks, Dr. Brooks. Yep.
I would echo most of what Chris said, particularly the infodemic manager training. As somebody who isn't intimately involved in the work that CDC and WHO have been doing on that side, it's been very impressive to see how they've developed it and the amount of work they've done and how many people have been trained. one thing to keep in mind from I'll use the academic hat. I mean, I obviously work in kind of the cross space between academia and practice. But as far as infodemiology is concerned, the study of infodemics, this is an academic field that has been around for quite a while, but it's been very, very scattered. It's only really been the last couple of years that this has been coalescing into a field of study, I would say. I mean, the first journal I know of that was dedicated to infodemics and infodemiology started, I think, last year or maybe the year before. That's a more on the kind of formal side, but it tells you, no, we're really at the beginning of this. So now Chris and I think have been really on the front edge of trying to figure out, how do you respond to this in a structured, formal way? Chris has been doing it much longer from the vaccine confidence side. We're challenged not to just do it for COVID, but can you develop things that will be completely generalizable? So yes, keep an eye on what is coming out. Certainly, and I'm one of those 1,000 or so subscribers to the confidence report. Keep an eye on what Tina Pernad and her team at WHO are doing. There is a lot of good work going on.
Yeah, thanks both of you. And I would really say the same thing as well, right? That I think the very fact that all of you has participated in this event clearly shows that you are interested in this topic itself. And in fact, all of you has really built this community, right? And now that you know who are some of the leading researchers in this field, so you have all the resources and you have now really built a community within itself. Reach out to each other, keep each other informed, and I think that will probably be one of the best ways to grow, right, in this area. So the last question I see here, right, is now many people have actually compared infodemics to an actual pandemic itself, and obviously you could see a lot of similarities, right, and relevance, especially in terms of how you would treat the prevention algorithm. So things around understanding what's the agent that's spreading, what's the medium, very much like a pandemic itself, what's the means the agent is spreading, and what's the network of connections and interaction that actually help the spread. You need to emphasize around the detection, the surveillance mechanism, right? And then subsequent to that is the treatment part, right? So the countermeasures involved and so on and so forth. So there is really a lot of similarities that you could draw relevance and I'll say lessons from, right, on how you would treat pandemic versus infodemic. Now, either one of you, feel free to just chime in terms of what are your views on how you would actually apply lessons learned from, methods of treating pandemic into infodemics, and what are some of the tools and mechanisms that you would propose to use based on your experience. So over to both of you.
And if I may, I'd like to turn that around slightly. And there's a couple of questions of what is different. And one of the things is that this isn't adversarial, or can be an adversarial process, which is different. I mean, the virus mutates, and we're always trying to keep on top of it. But it is not as smart as people who are trying to spread disinformation, and it doesn't mutate as rapidly as some of the misinformation and disinformation spreading. There was another point. What was the second point I was going to make? So, Chris, if you go, maybe.
Yeah, maybe we'll come back to you, right, Dr. Brooks, Dr. Vogeli.
Yeah, I would say there are a lot of similarities to it. I think there's a lot of nuance and differences between the two as well. But I think there's lessons to be learned there. One of the variables that we often consider is the believability of it. And I often relate that to the infectiousness of it. But also there's the end state of them, right? The mortality, morbidity outcomes of it. And for us, we call that the potential for impact, right? On whatever health concern that we have. So there is a lot of overlap, but I continue to be concerned about over applying those methods to health information being spread, because there are a lot of differences in there. And maybe it's my psychologist training coming in, but the human mind is a unique beast. And one of the concerns, like I mentioned earlier, that we continue to see is this fear of the unknown, right? This fear of something that we just can't tell yet. And from the psychological perspective, that's one of the biggest fears, or the most impactful fears we have. And those kind of ideas are hard to wrap around in a surveillance epidemiology mind frame, because that's just one of many things impacting it. But there could be relations, right, between all of the different variables that contribute to the spread of the disease and something like that. But it's just complicated by that human piece, that psychological component so much that it gives me caution a little bit.
Indeed. Thanks, Dr. Vogeli. Dr. Brooks, have you recalled your last point?
Yeah, yes. I recorded a point. I think one of the similarities is something that we just touched on a couple of times. The reason that we were able to get a vaccine out so quickly, and people have been using the fact that we as a community were able to develop a vaccine as a bad thing. They've been using that as arguments that this is fake, it was all planned. The reason that we're able to do that was because there's a lot of hard work gone into the background in preparedness. That's where, going back, this is where we need to be taking the time, where maybe it's not the immediate crisis to be preparing, so that if you look at the inoculation theory of responding to misinformation, to develop those information vaccines, the health knowledge, the resilience, and the understanding of what is misinformation, now is the time to be doing it, to prepare the population to understand and be better at recognizing conspiracy theories and pseudoscience.
Great, thanks, Dr. Brooks and Dr. Vogeli. Yeah, I think we're almost at time, and I would think that we would really want to wrap up. But before that, I would really like both of you to probably just summarize the thoughts, right? Especially around today's theme, or rather the theme of this year's conference, right? Which is social media and public health. Is that indeed a friend or a foe? Right. So if you could summarize your thought, each of you, in a single word, now what would that be? Dr. Brooks, maybe over to you first.
I'm not sure I can do it in a single word. It's complicated. I mean, social media is not a monolithic thing. Different platforms have different relationships. Some are easier to work with than others. You ask about policy. From my perspective, the fact that the vast majority of social media conversation is completely invisible because we can't see it, because it's being shared privately. That's a problem for me. I mean, yes, there's lots of privacy and ethical considerations. But from a purely public health perspective, not being able to see 90% of what the discussion is online is a problem. And from an international perspective, Chris, you were saying that you've never asked for posts to be taken down. Those posts that are being fact-checked and removed, they are very much heavily in favor of English. You'll see the same stories that have been fact-checked and removed in English, but which still exist in other languages. That's a function, I'm sure, of the resources of the platform. Friend or foe? Varies. It's both.
That's what I was gonna throw out, the word complicated, or cautious maybe. And just to Dr. Brooks' last point, that all social media platforms aren't equal. And a lot of the times we focus on those that are publicly available, but what about those on the dark web that need special tools, resources to get, and the sort of implications that come with that? I'm not sure it is a friend or foe, and that it's just another communication method. And we have to start to think about, how do we deal with that? How do we ensure that, it's not contributing to the problems? But I go back to the example of the press, right? That really wasn't, it's not to destroy the presses, it's to enact policies to make sure people aren't endangered by those. And yeah, I continue to see social media as a tool, with the caveat that there are things about it that make it problematic. I think of YouTube and their algorithm showing you not exactly what you're interested in, but what will drive you to watch more videos, right? Like that's a unique conundrum, because they often do become more extreme videos as you go. So those are the type of concerns and issues that are really left up to the social media space. And at least in the US, the issue of free speech continues to be a consideration, and an important point. I feel like there's a piece to rant there, but I'll leave it. Yeah.
Right. Thanks, Dr. Gili. And I think I will concur, right, that the word complicated truly summarizes the current situation that we're in right now, especially in terms of how social media really impacts, well, not just public health, right? It does impact, your individual personal life, corporate images, even in the political scene as well, right? So how it has forever changed the landscape. So with this, what I would say is that it's definitely, first of all, it's a great session. I think we see a lot of interactions, a lot of interest from the audiences in terms of the work that both Dr. Brooks and Dr. Vogeli have done and shared. And we definitely have learned a lot. So what I would propose right now is and I do see that Dr. Babich, our academic advisor for this event as well, has joined. So can I maybe invite all of you to, turn on the camera, and then we can have a group photo before we, proceed to the next segment. Hey, Dr. Babich, morning.
Good morning. Good afternoon. Hi, everybody. Thank you, speakers. Fantastic discussion.
Right, so Tiff, I'll hand the time over back to you.
Yes, I am just waiting a couple of minutes for everyone to be able to turn on their cameras, and then afterwards I'll take the picture and we can leave the floor to Professor Babich. Okay, wonderful. I will take the picture now. All right, done. Thank you so much, everyone.